Okay guys, today I'm going to show you in this video how to perform an NG tube insertion. That stands for nasal gastric tubing, okay? The good thing and the awesome thing about this, there is no sterile technique involved at all, okay? It's a clean procedure, not a sterile procedure. So again, the first thing that you want to do is to verify the orders, stating that the doctor has ordered for this patient to receive a nasogastric tube. We will talk in class the background and the reasons behind why a patient may need an NG tube. Okay, so you want to check and verify those orders. You want to go in, introduce yourself to the patient, again, provide privacy, explain to the patient what the procedure will entail. Of course, verifying that you have the correct patient using those two identifiers, name and date of birth. Remember, as the patient state their name and date of birth, you should be actively looking at the bracelet, verifying the information is the same. We also need to do what? Yes, check for allergies, okay? Remember to be specific. So with this particular procedure, latex, 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 our gloves, the tubing, mostly anything that we're using could actually have latex in it. If the patient doesn't know or states they do have a latex allergy, you want to make sure that you are verifying the items that the supplies that you're using does not contain latex. Now, tape. We will use some adhesive. Now, there are manufactured NG tube placement holders. We don't have them, unfortunately. We're just going to use regular tape. But again, that is another allergy we need to verify. Are they allergic to tape or any type of adhesive? Again, not very common, but we may even use some lube, okay? Now, once we verified our allergy, explain and inform the patient about the order for the NG tube and made sure that we have an order and that we have the correct patient, we are going to take our time to educate our patient. Okay, we will want you to state these things during your checkoff because it is important to educate your patient before you do this procedure. It is very invasive. It can be very scary and very uncomfortable. If your patient understands what is happening, when it's happening, and you provide them with like a safety sign to say, hey, stop, give me a minute to catch my breath, it will make the procedure go a little bit more smoother. Okay. So as you see here, I already have my patient in a high Fowler's or 45-degree angle. Think of high Fowler's or 45 degrees as if someone is sitting straight up, as if you were sitting in a chair at the dinner table. This is very, very important. The reason being is when we begin to insert this NG tube, it can elicit the gag reflex, causing the patient to vomit and then aspirate, meaning that some of that vomitus will go into the patient lungs. Okay, so it is so important that that patient is in a high Fowler's or 45 degrees in the bed. Again, you want to make sure the patient's bed height wise is up to a position that's comfortable for you so you don't hurt your back. Okay, you want to protect your back. So now some things that that you need to be asking the patient before you begin is we want to ask the patient some questions to sort of determine how well this procedure is going to go, or trying to foresee any possible uh, issues, okay, that we may encounter. So I'm going to sanitize my hands, putting on clean gloves. Again, this is strictly a clean procedure. So I'm going to ask the patient a couple of questions. One being, I want to check for patency of the patient nares or nostril. And how we check for patency, do a couple of things, okay? Get you a pen light and inspect the nares. Okay, seeing if you can see anything. Now, I will say this, a lot of the problems in the nasal passage will not be visible when you check the nares with a pen light, okay? The problems are further back. Patients could have nasal polyps that you can't see, or the patient could have had a broken nose or a fractured nose or nasal surgery. So what you want to ask is, have you ever had nasal polyps? Have you ever been had nasal surgery? Have you ever broken your nose? Okay. Those things can sort of give us an idea. If we start having a lot of issue inserting that tube, we may need to stop, contact the provider, let them know, hey, this patient has a history of a couple of nasal fractured nose fractures or nasal surgeries. The patient may need to be taken to the operating room where they are sedated and the NG tube is placed there. Okay. If you're having a difficult time, please don't force it. We do not want to cause the patient to start having nosebleeds and so forth. Okay. So now another way to test which nair we're going to use is have the patient close one nair or nostril and have them to breathe. Okay, and then close the other nostril, breathe. Okay, for me, I have nasal polyps in the left nair, and you may even have heard that. So it's much clearer on the right. In the right nair, I get more air, and the patient will tell you, yeah, I feel less congested, or I'm getting more air in the right or left nair. That's the one we're going to go with. Okay, so that's a couple of ways to test the patency of the nairs. The next thing we want to do is explain to the patient how this is going to go, okay? So we're going to tell them that we're going to take this tube, and you want to speak in layman terms so that they understand it, and that you're going to go up their nose with this plastic tube, down the back of their throat, and into the stomach, okay? And you explain it just like that in layman terms. They will ask, is it going to hurt? For some patients, this is very uncomfortable. Just say, in some patients, this procedure can be uncomfortable, but it's okay. We're going to talk through it. I'm going to take my time, and you're going to be fine, okay? In certain situations, if the patient is very nervous, you may need a second nurse or someone with you whose entire job is just to keep giving this patient positive feedback and ensuring them that they are doing well. Okay. So now you want to tell the patient at some point, okay, I am going, when I'm inserting the tube, once I get to the back of your throat, I am going to have you put your chin to your chest, and I'm going to have you take this cup of water with the straw, and I'm going to have you suck through this straw. When I say swallow, 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 you're going to swallow, and that is going to help facilitate the tube to go down the throat, okay? The reason why we have them put their chin to their chest is because if we have them put their chin to their chest, then this sort of keeps the tube from going into the airway down into the lungs versus into the stomach, okay? So there's a method behind the madness. Now you're going to explain to the patient, when we get to that point, I will have you put your chin to your chest and have you swallow, take a sip, drink from the straw, swallowing, and almost like forceful swallows, because that the muscles will help pull that tube down. Okay. All right. So you're going to also tell the patient, at any time, if you need me to stop, please don't grab the tube or grab my hand. Instead, raise your right hand or raise your left hand, okay, or pat your leg, and I will stop. Now, you're not going to pull the tube back out. You're just going to stop, let the patient gather themselves, take a deep breath. Okay. Again, this can be very hard on some patients. Okay. Giving them that safety sign, gives them a sense of control over what's happening. All right. So I have my cup of water with the straw. I also have a basin here. The reason for the basin and what you will explain to the patient is that this basin is here in case we elicit that gag reflex and the patient begins to vomit. Okay. We want to make sure they're leaning forward and we have something to catch it. Also, it is very helpful to have this basin because we can put the end of the tube in the basin, and sometimes some patients' bellies are full with fluid, and it will immediately come pouring out, and we have something to catch it. Okay, so explain that to your patient. So now we may ask you some questions during checkoff, such as how do you know when you may have entered into the patient's lungs? Okay, because it is possible. The trachea and the esophagus, they're sitting there hand in hand, right close together. So one sign is the patient will have these coughing spells. Now, this procedure just by itself can cause a patient to cough, especially once the tube enters the back of the throat or the oropharynx area. However, very forceful coughing, like they're gagging or something like that, can be a sign that you're in the lungs. In that case, you want to pull the tube back, not out, but just pull it back to where you can see the end of the tube in the back of the throat, sort of let the patient catch their breath. Okay. Some patients may be hooked up, or you can hook them up to a pulse ox monitor. And if their pulse ox or oxygen saturation begins to drop, you know that you are in the lungs. Okay. Another way to check is that when you insert this tube, you will see almost like you will actually see when the patient takes breaths in and out, you will see like condensation within the tube with each breath. That tells you I'm in the lungs. Okay. Patient's lips turning blue, oh yes, we are well in the lungs. So we don't want to get to that point. Okay. So those are some signs that we may ask you. When do you know you could possibly be in the lungs? Okay. So now what you're going to do is, I have here a couple of things. I have a pH testing strip and I have some lube. I have here what they call a piston syringe. Okay, looks like this. Take that little cap off. Okay. Again, none of this is sterile, but we want to keep it clean because it's going, into someone's body. And then I have my NG tube here, or what we call a Salem sump drain. And if I can get it open, again, this is sterile. It comes sterile, but we do not have to handle it in a sterile fashion. Okay. The mouth, all that is dirty. So this is what that tube looks like. This is the end with the little fenestrated openings. This is the end that will go into the patient nose down into their stomach. Okay. I have a safety pin here. So once it has been confirmed by x-ray that the tube is in the correct place, we're going to fasten that to the patient's gown. And I have some tape here. And then I have a little cloth that we're going to drape over the patient's chest just to protect their gown. So I'm going to pull this back a little bit. The first thing that we have to do is measure our tube. Okay. So we know how far to insert this tube. Okay. And how you do your measurement, again, the tube does not have to be sterile, but we want to try to keep things clean. This is going inside of a patient's body. So I'm just going to lay this here. You definitely want to have on gloves, even when preparing your tube, because again, you're putting this inside someone's body. So how we measure this tube to see how far we need to insert is we take the tip and to the tip of the nose. Okay, so tip of the nose, tip of the tube, to the earlobe. Okay, and you're making sure now I got it pinched here at the tip of the nose, securing it. I measured it to the earlobe. I'm going to let this go, but I'm going to keep my finger at the earlobe. Okay, because I don't want to obscure my measurements. Okay, obscure my measurements. So I'm now pinching it or securing it at the earlobe, and then from the earlobe down to the xiphoid process. Okay, now on these mannequins it is hard to feel the xiphoid process, but if you just touch right below the breast area, if you just touch here at the end of the sternum, that's the xiphoid process. Feels a little like a little pointed bone. That's what you're feeling for. So I'm measuring at about 50. Okay, so now I can let go. If you can remember what you measured at, that's fine. But best practice, go ahead and tape it, because as you're inserting this tube, you can't see the numbers depending on how the tube is turned. But if you put some tape there, once you get to the tape, you'll know that I am at the proper measurement. Okay. All right. So we're ready to begin. You're going to let the patient know that, hey, we're getting ready to start the procedure. I'm going ahead and cover their chest. Put this here. They have their water. Look at your facility's guidelines. Some facilities allow you to use lube. Other facilities will not allow you to use lube. They'll allow you maybe to moisten it with some water or something like that. Just follow your facility guidelines. So we're using lube. So we're going to lube the tip, not a lot, but just to make it easier on the patient. Okay. So now what I'm going to do is, with the patient sitting up, at this point, I'm going to start inserting the tube into the nasal pharynx. Okay, so that's this region here. You want to get the tip of the tube. If you hold it way back here, it's going to make it flimsy and you're going to find it very difficult. Okay, so sort of get at the tip. Okay, we said we're going into this patient's right nair. So we're going to start into the right nair and we're going to start inserting. Now, these mannequins, some of the mannequins that you will be using will not allow you to go all the way to the 50 mark. It may stop at 25, although you've measured it at 50. That is okay. We are aware of that. You would just state it is at the 50 mark or at the tape mark, okay? So I'm going to start inserting. Please give yourself some grace like me, because these mannequins, these tubes will tend to curl up behind the eyeball for whatever reason. So you just sort of keep pushing on a real patient while you're entering the nasal pharynx. That bony area can cause a lot of difficulty passing that tube. So you may have to rotate the tube, okay, like such. I'm doing a twisting, pushing motion to get it up and past that nasal pharynx region. So now, at that point, when you have passed the nasal pharynx region, there's no bony structures there, you will feel that tube start to glide, okay? But don't get too happy. Once you feel the tube passing easily, you want to stop and you'll say, I'm looking in the back of the throat. I see the tube, okay? So you know we have our uvula there. You should see the tube back there, okay? Look before you have the patient put their chin to the chest. Make sure you look in the back of the throat to verify you see the tube, because having them put their chin to their chest and swallowing the water is not effective if the tube is still in the nasal pharynx region. It has to be in the oral pharynx region or the back of the throat, because you're utilizing the throat muscles to pull the tube down and also chin to chest. is making sure that the tube does not enter the airway. Okay, so you're going to stop, look in the back of the throat, and you're going to state, I see the tube. You will not see the tube on these mannequins. You will just state that you see the tube. Then you're going to, once you see the tube and state that, at that point, you will tell the patient, get you to Miss Johnson, I'm going to have you put your chin to the chest. In the real world, actual clinical setting, it is okay to take one hand, place it behind the patient's head, and you're not forcing their head down, but you're sort of offering some resistance, because naturally when something is going up our nose, we're going to back up away from it. So you want to use the back of your hand to sort of keep reminding them, no, 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 chin to chest, chin to chest. So at this point, you're going to say, okay, chin to chest, and you're going to tell the mannequin, now start swallowing your water. And you're going to say, chin to chest, swallow, 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 swallow. You're doing great. Chin to chest, swallow, swallow, until the tube is all the way to the tape. Now, this mannequin is one of the mannequins. It will not go all the way to the tape. Our tape is still here. You would keep inserting now until you got to that tape, because that's where you measured. So, but for checkoff purposes, when you can't advance the tube anymore, just state that, and we will pretend that you have advanced it to the tape, okay? So we're going to pretend that we have advanced the tube to the tape, okay? That's our 50 mark or 52 mark. So we've advanced the tube. Now you tell the patient, take a deep breath. You're okay. You're relaxed. You see I have the end of my tube in the bucket. So if anything starts to drain, it can drain in that bucket, okay? So now what I'm going to do is I'm going to temporarily secure the tube. Now, in the clinical setting, they have special securement devices for NG tubes. We don't have them here. And basically, it fits over the bridge of the nose, and it holds the tube in place, okay? To temporarily secure it until it is confirmed by x-ray that it is in the stomach, you can just temporarily, without covering the opening of the nostrils with your tape as such, okay? Please don't temporarily secure the tape to the patient's face. If patients do have an allergy or an elderly patient with thin skin, when you take that tape off, especially if you use those securement devices, it can also remove skin, okay? Never put that on a patient's tape on the side of their face. You want to just secure it to the nose. Okay, so now what we're going to do, we're going to keep the patient up in this 45 for their safety, because the patient will still be coughing or gagging a little bit. We don't want them to aspirate while we're waiting on x-ray, okay? But before we call x-ray, we are going to now check the pH. Now, we're teaching you this method, but not all facilities use this pH testing. Most facilities, once you measure it and you're able to insert the tube up to the measured line, you will then temporarily secure it, contact x-ray. X-ray will come to the patient's room, x-ray, and confirm placement. Or they'll say the tube needs to be advanced 2 or 3 more centimeters or pull back 2 to 3 more centimeters. Now, let me tell you, mention this. In ATI, it will say that once you get the measurement and you've inserted it up to your measurement, to insert an additional, I think it's something like 20 or 30 centimeters, no, you're going to be too far. You could actually go into start entering into the small intestines. So for us, checkoff purposes, you're just going to insert it up until the tape or where the line you're measured at. So now what I'm going to do here, I'm going to take my piston And I'm going to pull back just a little bit, 5-10 cc's of any gastric content that may be in the tube or coming through the tube, okay? Again, all facilities don't do this, but some may still do, and that's why we're teaching you. You would take your pH paper and you would put some of that gastric content on that pH paper to determine the acidity level of that pH. If you have any remaining gastric contents, you're going to insert it. That is what ATI states. But as you see here, if you're only pulling back about 5 cc's, you're literally going to utilize all of that on your pH strip, and there's nothing to put back. And also, we're putting in this NG tube to possibly remove gastric content that, for whatever reason, a blockage will now not allow it to go down into the intestines, okay? But I just wanted to mention that because it does state it in ATI. Okay, so now my pH paper, I wait. If it's like a 2 or 3 pH, you know that is really acidic. You're most likely in the stomach. If it is 5, 6, 7, 8, that is very basic, okay, or alkaline, and you might be in the lungs. All patients do not react to the tube being in their lungs, okay, depending on where the placement of the tube is in the lung. So you want it as acidic as possible. So below 4, you're pretty good to go, okay? So ours, we're going to say is 3, pH level is 3, we're good to go. So now, going to keep everything set up like this. Put the patient's call bell within reach, lower the bed to the lowest position, make sure all bed rails are up, and explain to the patient, please don't pull on the tube or remove the tube. We're waiting on x-ray. So during checkoffs, once you complete this portion, then you'll say x-ray has come and confirmed the tube is in the stomach, okay? We don't need to advance it. We don't need to pull back. In the real world, if you had to advance it 2 to 3 more centimeters or pull back, if you had to do any adjustments after x-ray check placement, you would then have to fix it and then contact x-ray again, okay? Once x-ray has confirmed it, we can pretty much now secure our tube, okay? Secure our tube to the patient, okay? Now, we have ours already taped to our patient's nose. And then what you will see is some people, they will take like a little loop of the gown, or they will take a piece of tape as such. You know, however you choose to do it is fine. Make a little loop strip here, and then we would fasten this to the patient's gown. Now, the reason why we do this is because you don't want this dangling. It's going to cause irritation, just like with the catheter, with the pulling and dangling. Patient's nose can get very sore. The skin can break down. Just like the catheter, leave a little bit extra, okay? And how you can test it, have the patient, you can fasten it here, then have the patient turn their head to the left, to the right, and ask them, does it feel comfortable? Is the tube pulling? And if they say no, then you've got a perfect fit, okay? So we're good to go. At this point, I would offer my patient some mouth care. Usually the patient is NPO, or they're only allowed to have chips, ice chips, and so forth if we're giving the stomach a rest. Again, we're going to talk about the different reasons behind NG tubes being ordered and placed. And we're also going to show you in the lab how to hook the NG tube to suction. And actually, I'll go ahead and do that now. So I'm going to remove this, clean my hands. And put on another pair of gloves. Now I want to state this. You cannot hook this NG tube up to suction. You cannot flush this NG tube with water or anything else. You cannot use this NG tube to give the patients medication. You can't do anything with this NG tube until X-ray has confirmed placement, okay? pH just lets us know we're in the right vicinity before we call X-ray. It is not confirmation, okay? That's the NCLEX question. So also you cannot hook this NG tube to suction unless you have an order. The order would state hook to intermittent suction or low continuous wall suction, okay? But you need an order, okay? So just remember that if it's passing meds through the tube, feeding through the tube, you need an order. So we're going to pretend that we have an order to hook our NG tube to low continuous wall suction, okay? So I'm going to come around on the other side here. Okay, so you see this is for our suction, okay? This is to operate our suction canister here. Green is oxygen, and then the yellow is medical air. Here's another oxygen valve. We won't be using that. And here's another piece for suction. So as you see here, you have your suction canister, okay? And as you see, you will need 2 tubes, okay? This stays closed. This is how you empty it. So that stays closed to provide the negative air pressure that you need. You will use that little extended piece to hook one suction to that nozzle. And then your other tube, you will hook to that nozzle, okay? This must be closed, else it will not properly suction, okay? And it fits up here. This tube is going to be connected to the NG tube. The blue tube is being hooked to the wall suction, okay? You may not be able to see on this, but you can take a look at it in lab and play with it. So you have one line that says CONT, that's continuous. Then the middle says off, and then you have another section on this end that says INT, that's intermittent, meaning it will suck, stop, continuous, it continues to the suction continues. Now you see you have in millimeters of mercury is showing you the amount of suction, how powerful the suction is. In the green, that's low suction, and that's anywhere from 0 to 80 millimeters of mercury. Medium suction from 80 to 120, and then high and full vac. You should question orders when it is on high or full vac. That can be too strong, and it can actually cause some damage to soft tissue internally. Usually they will have low continuous or low intermittent wall suction, anywhere from 20 to 80 millimeters of mercury, okay? So we want to cut the system on. You hear that suctioning. Now this is off, but if I put it to continuous, you see the needle went all the way to the full vac. So I don't think this one is working. There it is. So I'm going to turn it until it's in the green area. And the provider will even have orders, say about 60 millimeters of mercury or 55. So we're going to go with our 55. That's what the order is. And you can see it there. It's on continuous because our order is for low continuous wall suction, about 55 millimeters of mercury. Okay. I'm covering this in order to test the suction. Okay. So now I'm going to go ahead and connect. Remember, I need this piece. Hook this to the clear end, okay? Because this is going to allow for the gastric contents to be sucked out. So clear in and then connect, okay? What you will find is that it will start suctioning the contents, okay? And that's how you hook your NG tube to suction. Now we're going to get ready to remove our NG tube. So before you remove an NG tube, check the orders, verify that you have the right patient using. Hi guys, lost audio here for some reason, so I'm just going to talk over this next section. So right here, basically, I'm just explaining that before you remove the NG tube, please ensure that you have disconnected the NG tube from suction. You do not want to remove an NG tube while it's connected to suction, because you can cause damage to soft tissue, such as in the lining of the stomach or the esophagus or the inside of the nares. So here I'm just disconnecting my suction so that I can prepare to remove the NG tube. Just want to add as well, you always want to make sure before removing the NG tube that you do have an order to remove the NG tube, okay? So now here I'm just explaining that we want to go ahead and protect the patient's gown or clothing, because sometimes we can have some gastric contents that is still inside of the tube when you remove it that could get on the patient, okay? So that's what I'm explaining in this step here. And there I have the piston syringe, and I'm going to show you in a little bit what we're going to do with that syringe. We're going to pull up some water, about 20 cc's, and flush that NG tube just so any remaining gastric contents can be pushed back into the patient's stomach. Now here I'm just removing the safety pin from the gown and loosening the tape on the patient's nose. You want to do all of that before attempting to remove the tube. Just placing a basin here, just because the patient could actually have a response to you removing the tube and, you know, feel sick and may have some emesis there. And also some contents could be coming out of the tube when you're trying to flush it. So here I'm just flushing it with about 10 or 20 cc's of just water, okay? And again, this is just to push any gastric contents back into the stomach so that when we remove the tube, we won't have those gastric contents getting onto the patient. Okay, so you're just explaining to the patient what you're going to do at this point, letting them know that you're going to remove the tube, and you can have them take a deep breath as you remove that tube. Okay, so I'm just going on here basically explaining how you would talk to your patient, again letting them know the process of removing the tube. And now we're removing the tube in a slow, steady motion. Okay, so now that tube is removed, I am looking at it to make sure that that tip is intact, just like with our Foley. And you will document tip is intact and patient tolerated the procedure well. So at this point, I'm just explaining you would offer any mouth care or anything like that to the patient after removal of the tube. Okay. Also, you can offer to lay the patient's head back, put the bed in the lowest position, and provide them with their call light. At this point, there's no need for the patient's head to stay in that 45-degree position. Always remember to put the bed in the lowest position and provide the patient their call light before leaving the room. All right, so we're all done here with our video on NG tube insertion and removal. Afterwards, you would go ahead and clean up your supplies and make sure you clean your hands. Thank you so much.